I'm going to walk you guys through how to do a shoulder arthrocentesis. The shoulder itself, when you think about it, it's a relatively large joint, but just remember the space that you're trying to get into in terms of getting fluid out of the shoulder is relatively deep, so it's a moderately difficult technique, but definitely not impossible. The key before I show you the patient positioning and landmarks is to remember this is an aseptic technique, right? So you're going to want to do this aseptically, clean them, and also doing the local anesthesia. That's all covered in our tips and tricks of arthrocentesis video if you need to review how to do that. But let's walk you through how to do this actual approach. In terms of positioning the patient, I'll have them sitting. I'll have them rest their arm to the side with their hand on their thigh. This really kind of just relaxes the shoulder musculature and opens up that joint space. Always remind them again to relax their shoulder. You want them to be tense, and tensing up those muscles just closes up that space for you. In terms of the landmarks, there's two that you want to be aware of. The coracoid process, right, which is going to be that lateral aspect of the clavicle that's easily palpable. You feel it right there at the end. It almost makes a 90-degree turn as it goes towards the AC joint. So you want to have that. That's your medial landmark. And then your lateral landmark is going to be the proximal humerus. I've outlined both of those here with a little marker so you know where it's at, but you just find that part. You can almost feel the ball of that proximal humerus. In terms of where you're going to be going with the needle, remember you're going to be going just inferior and lateral to that coracoid process into that space, and you're going to be aiming that needle posteriorly towards the glenoid rim. So that's where you're going to want to inject your anesthesia, and that's where you're going to want to be introducing your needle for the arthrocentesis. So I'll take my thumb and kind of just hold it on that coracoid process right there. I kind of know where this is, and sometimes you can even outline this with a sterile surgical marker if you like, if it's helpful. And then take that needle again just inferior and just lateral to the coracoid process, aiming it a little medial and posterior towards the glenoid rim, aspirating as you go along until you kind of get a fluid coming back. I'm using a smaller syringe for this demonstration, but typically I'll use anything from a 20 cc to a 30 cc syringe. You typically aren't going to get 30 cc's out, but you don't want to have to be switching that out if you can avoid that. Plus, a 20 cc and 30 cc syringe is large enough, but not so large that it's uncomfortable in your hand. In terms of the needle, I usually use a 20 gauge needle, and I want to make sure it's long, so at least 1.5 centimeters, if not longer, to really get into that space, to get into that joint space that you're trying to approach. So once you're in there, you can aspirate the fluid that you need for diagnostic or therapeutic reasons and put in medications. Classically, people will use this approach when they're doing local anesthesia for a shoulder reduction. Just remember, when you're doing a shoulder reduction, this space here is going to be a little bit larger, right? Because that proximal humerus is going to be down and a little anterior. So you'll still have your coracoid process, but now you have a larger space. So classically for that, I use my coracoid process as my landmark, and just remember going towards that glenoid. And you can fill that up with, a topical anesthesia and get good shoulder reduction without having to do procedural sedation. And that's pretty much it for the shoulder arthrocentesis.